This is Dr. Eric Potter from Sanctuary Functional Medicine doing a Sanctuary Live on this wonderful June 10th, 2021. I'm going to ramble on here for just a minute to let some people get on board and make sure everyone can hear me. We have been working through technical difficulties over the last several episodes as feel like every time my software and audio video equipment has decided to have a different set of rules, but regardless, we are going to do our best to make this one be productive. So again, if you are just joining us, this is Dr. Eric Potter from Sanctuary Functional Medicine here in Franklin, Tennessee. Can you hear me in there, Ron? Alright, I think everybody is working here. So, alright. So first of all, we're going to talk about long hauler COVID today. Long COVID, post acute SARS-CoV-2, lots of different names. But we also need to get this out of the way. As always, just the disclaimer, this is not actual treatment. I can't diagnose over the internet, especially for someone who I've never met. Or even those I'm already caring for, we need to have a dialogue. But this is meant to be educational. Do not go home and implement these without the guidance of someone who knows your healthcare and is trained. So with that, again, we're going to talk about long hauler COVID. This thing that we are learning about as we have gone through 2020 and 2021. For many, COVID caused by SARS-CoV, these little virus that is wreaking havoc in our world, comes and goes. It can be scary. For some, it causes practically no symptoms at all and goes away after about 2 weeks. However, there are many who are suffering for much longer from COVID, and they have what is called a long hauler COVID, post-acute COVID, post-COVID, lots of different names, but regardless, what it is meaning that someone who, yes, it may take a little while to recover from a virus, say a week or two to kind of bounce back from a bad flu, but after 4 weeks, you still have ongoing symptoms. Now, 4 weeks ago, the last fever, kind of what you thought was the real deal, is over, but now you're looking at fatigue, headache, brain fogs, even GI symptoms, orthostatic hypotension, meaning you stand up, you get rapid heart rate and dizzy, you have concentration difficulties, lots of different symptoms that people are reporting, random palpitations or heart rates that are going above 100, kind of severe deconditioning, post-exertional fatigue where they try to exercise and it wipes them out. So with that, we have these symptoms. They are occurring, say, at least 4 weeks, especially if they're out at 12, still occurring at 12 weeks. We are looking at more of the long hauler type because somebody who is in the ICU from being ventilated for COVID, it's reasonable to expect that it's going to take them a few weeks to recover. However, what we're seeing is that this may be in patients that had very mild symptoms to begin with, or even medium, and symptoms are going 4 weeks, 8 weeks, 12 weeks. Some people 4 to 6 months later, they are still complaining of these symptoms. Now, with that, how do you diagnose it? That's going to transition into the next talking about who gets it exactly. So how do you diagnose it? Well, there is not one consensus to say, okay, if you have this symptom, this symptom, this symptom, or this lab, and this lab, for this amount of time, you have post-COVID. The diagnosis is developing. You think, well, don't you just know if you have it or not? Well, it is not that clear in medicine, especially when we're dealing with something new like this. For example, so if you have a headache, does that mean you have post-COVID? Well, or you had COVID 6 months ago and you didn't have any headaches, but now you have a headache. So we have to have clear definitions, because if we are going to treat someone or a group of people, we need to know that we're treating the right thing, that we're not blaming COVID for a headache, that it really is related to something completely different. So with that, different groups are working, but it is at the very least one of the symptoms I talked about earlier, especially if there's 2, 3, or 4 of those symptoms, that has persisted, may have gone away for a little while, but then come back and it's persisting for at least 4 weeks, and definitely at 12 weeks, everybody will agree that that is a long hauler or a post-COVID situation. With that, there's no other good explanation. So if somebody got flu afterwards or somebody developed some other disease, yeah, you blame that other disease for those symptoms. But no other disease, there's no laboratory findings pointing to something else that's happening, because there isn't a lab test to say, oh, you have long hauler COVID. Because technically, the virus is supposed to be gone. From what we can tell, there's debate whether there is ongoing viral replication, but symptoms for at least a certain amount of time without other explanations. Now, I mentioned about this is how we do things in medicine, and I'd like to just take a historical footnote for a moment and talk about the fact that with post-COVID being this post-viral syndrome, this is not a new thing. In functional medicine, we deal with this all the time, whether it's post-Epstein-Barr, whether some people having post-flu symptoms. You can even have post-gastroenteritis. You could have a viral GI bug that actually damages the lining, the nerve cells that run through your intestine and cause you to have ongoing irritable bowel syndrome. So even our lovely, I hate to say his name, but Dr. Fauci, when he first started talking about post-COVID syndrome, admitted that we deal with a lot of other post-viral illnesses that often get labeled as fibromyalgia, chronic fatigue, but EBV, CMV, HHV6, again, flu, parvovirus, there are other things that we deal with in functional medicine. Conventional medicine doesn't always recognize that, but we know that in functional medicine. So we have a diagnosis, we have some definitions there, and then let's talk about who gets post-COVID. Just like with regular COVID, not everybody suffers it the same, although it is different in one way. In COVID, with the severe form, it's mostly the elderly or certain other medical conditions where the kids are relatively spared. The younger you are, the safer you are. With post-COVID, while kids don't get it very often, they may get a little bit more. Younger, 20s, 30, 40-year-olds often get it more than you would otherwise expect. And it's not just the patients who had a severe ventilator episode or a severe hospitalization. It can be patients who had very minimal disease, just a mild cold from their acute COVID, may end up getting very severe COVID. So those are the who's. And now looking at exact numbers, it may be, there's difference of opinions. Some studies that say, only 10% of people who had acute get post-COVID long hauler, whereas other studies would say that maybe even 30% have some persistent symptoms when they're in their 30s and 40s, and then that going upper 20% going 30% as you get in the 50s and 60s, and above 60 more into the 40%, sometimes closer to 50% range. Some would even argue that it's high as 3 out of 4. So there are a lot of people, when you're multiplying that times hundreds of thousands, if not millions, there's a lot of people who may be experiencing some ongoing symptoms. These may last, again, 2 or 3 months and then resolve, but some are having ongoing, where it's interfering in life for even months and months at a time, and still not resolving 6 months or more later. So some of the other risk factors, there's at least one study that says it's not asthmatic patients. They don't get as much post-COVID syndrome. There are others that those who get it, again, a little more severe are more likely, but even the mild cases can get it. Hypertension, diabetes, metabolic issues, obesity, systemic inflammatory conditions seem to get a little bit more post-COVID. And then in our clinic, where we take care of patients whether it was Lyme, chronic yeast issues, chronic EBV, that we talked about a moment ago, we see a few more of those seem to be a little more risk because they're already inflamed to begin with, and then you're just throwing a little fuel on the fire, which gets us actually next to the mechanisms. So mechanisms, how's this happening? Why is it that sometimes viruses, you get one, you're sick, it goes away, and you're done with it? Well, like I said, it's not always the case. Some viruses do have some lingering effects, but probably the vast majority do not. So what makes COVID different? Yes, we know it's different, spreading around the world, scaring everybody's pants off, But what it appears is the dysregulation that's occurring with COVID. Now, interest note, any virus, in order to infect someone, has to turn off some part of your immune system defenses. It's like if someone breaks into your house, they've got to turn off the burglar alarm. They've got to turn off the alarms, or at least bypass something so they can get in and out. With COVID, any other viruses, they have different ways. Our immune system has a multitude of ways that it defends ourselves, but different viruses will attack, whether it's natural killer cells, turning down antibodies, turning off protein production, turning down fever, lots of different ways. With COVID, it also, again, dysregulates the immune system, so it can have a fighting chance in your body. It appears to have some different effects on natural killer cells. It lowers the number of CD4 positive helper cells, the cells that help keep your immune system turned to the right dial, not too much and not too little. It affects CD8 cells, which are actually one of the cells that help kill viruses or virus-infected cells, and influences your neutrophils. And it also has an potential autoimmune effect that we'll talk about in a moment. So, like other viruses, COVID appears to be dysregulating the immune system. And what appears to happen with post-COVID is, rather than that immune system going back to its regulated good state, it appears to stay in that dysregulated state. So even though the virus is dead, at least we think so, and gone, not replicating, although in many other post-viral syndromes like EBV, Epstein-Barr, it does continue growing, even though we don't have a way to definitely check it. With COVID, that dysregulated immune system continues to do okay for a while, but then starts spiraling out, causing more inflammation, causing tissue damage. And as I mentioned, it looks like it can cause some ongoing autoimmune issues. One of those they've recently found in a paper that just did a blog that's either out or coming out soon. We have antibodies against the endothelial cells in our blood vessels. Endothelial cells are those cells that line the blood vessels to keep what you want in and let out what you want to get to the local tissues, whether that's glucose, whether that's fatty acids, whether that's immune cells that need to get to an infection in the tissue. Our endothelial cells control that. Now, if they're being attacked with antibodies, then they are going to be leaky, and also they're going to be more likely to clot because they're trying to close off where damage is occurring, which is kind of what happens with a lot of heart attacks. Is you get inflammation in the blood vessel, triggers a clot, and it blocks off that blood vessel. And that's to the heart. It's a problem. If this does that, and COVID can cause that in the lungs, it can cause lung disease. If it can cause that in our brains, it may be causing stroke, or even not a full-blown stroke, but more minor neurologic symptoms, the concentration difficulties, the headaches, the attention issues, the memory changes afterwards. So when we're looking at that, we are trying to see where is this damage occurring, and it looks like it's immune dysregulation, potentially involving some autoimmune situations against the endothelium, which could be triggering this clotting. Now, the other aspect that we need to emphasize is, like I said, is this is post-acute, meaning it is something that happens after everything settles down, and that's one of the official names is post-acute SARS-CoV-2. But you also notice something else I've been mentioning. I didn't say this explicitly, but it's not like there's multiple mechanisms. It's not just this one thing. Our biological systems almost never, are just one little thing. COVID appears to be affecting, which is why in different ways, and probably why in some patients it's causing problems here, other patients causing problems in this other system. But when you step back, you say, oh, it's a dysregulated immune system. Now, what happens to these patients? We've talked about what it is, how you diagnose it, who they are, who the patients are, some of the mechanisms that we're beginning to understand. What happens to these patients? Well, some, just like with COVID, some get better on their own. They go through some physical rehab, go to your physical therapist. They have to do an exercise routine very slowly, building back up, getting over the breathlessness, getting over swelling, getting over these symptoms, or they have their symptoms treated. If it's a rash, they get some medicine for that. If it's some pain, they get some pain medicines. They go through that rehab, they take these symptom therapies. Some of them get better. They're still waiting to kind of get a sense as do 50%. Excuse me. I hope everybody didn't get deafened by my sneeze. But some of these, some patients will get better on their own. However, we have a lot that are lingering. And even if they get better in 4 months, what if we can do something to get them better in 1 month? Or what if we can do things during acute COVID that lessens the chance that they get the post-acute long hauler side of things? So we're looking at those numbers, but there are things now. The next step is looking at what can you do? What can you do more than rehab? Okay, well today I'm going to walk a mile, tomorrow I'm going to walk 1.1 miles, the next day I'll do 1.2. That's a slow, literally, slow recovery. What we're looking at is trying to find ways from things we already know. It's like I've mentioned before, we take care of patients with other post-viral issues in functional medicine. We've been doing that. And one of the first things is we want to optimize somebody's health. One of the big risk factors for people getting acute COVID and probably also post-acute COVID is what their general health was to begin with. If their immune system is dysregulated, it's easier to knock it off kilter even further. If they had a lot of inflammation, it's going to be easier to not, raise their inflammation another notch and leave them dysregulated. If their body was not functioning because of deficiencies, toxicities, other chronic infections, like we do every single time in functional medicine, we are going to try to work on those issues. From there, then we also look at the specific things for COVID, not just what we do for everybody, because that does help, but what do you specifically want to do with COVID? So the problem looks like hyperinflammation, so we're going to use anti-inflammatories. Sometimes that's glutathione, sometimes it's vitamin C, curcumin, different nutrients that we already use, fish oils. If someone has just general inflammation post-COVID, we're going to look at those. Again, talk to your doctor or myself if you're one of my patients before you implement those, because it may or may not be a good idea for you in a specific situation. But we're going to work on the anti-inflammatory aspect, turning down that, and other things that turn down what's called the NF-kappa B inflammatory system and turn up the NRF2 anti-inflammatory system. There's a number of things that do that, some of which we've mentioned. Now, we also want to treat symptoms. There's others that are looking at one of the potential mechanisms for post-COVID is having to do with mast cells. We deal with a lot of mast cell activation in our clinic due to dealing with biotoxins like mold and Lyme, but mast cells are a specific immune cell that releases histamine and probably 30 or 40 other chemical markers that trigger inflammation. They are communicating with other immune cells in our body to let those cells know how to respond. Oh, come here, help us with this infection. Oh, no, everything's good, you can go back to rest now. It is coordinating our system. If mast cell, and when you look at the symptoms of mast cell disease, mast cell hyperactivity disorder, versus post-COVID, a lot of those symptoms overlap. So it wouldn't be surprising that some of the therapies, things that we do from natural or pharmaceutical antihistamines, things that stabilize the mast cells like a quercetin, Kella, which is both of those are herbs, whether that's omega-3s that help calm that. There's a lot of different therapies we will use. We will try to calm down that mast cell activation if patients are having those type of symptoms. And then we look more at the specific. If somebody's having lung symptoms, we may think about using NAC, N-acetylcysteine, even if the FDA is trying to take it away right now. It loosens up mucus and seems to have some improvement. Actually, potentially somebody just sent me an article, possibly with acute COVID, but also with post-acute COVID, long hauler COVID as well. So if they're having those symptoms, mast cell symptoms, lung symptoms, if they're having energy symptoms, we might look at things that would help with the energy. If they're having sleep issues, which is another big issue with post-COVID, using melatonin, lavender oil, GABA, theanine, ashwagandha, a number of therapies that we're very familiar with and using for other patients seem to be helping there as well. So again, anti-inflammatory, considering mast cell, trying to get the immune system to function, optimize all the other things that are outside that they need to optimize in the first place, and then treat individual symptoms in different body systems. So with that, we try to help patients with post-COVID. We are looking across the board as new information comes in. I looked in the last 3 months and there's been 200 articles on PubMed about post-COVID. Now, a lot of those repeat a lot of the same information, but this is an area of active research, and in functional medicine we try to apply the latest findings, the latest information, not waiting for years, but to actually find out what is helping patients, apply it where we can now, with our understanding of the basic mechanisms of how our body functions, particularly in this case the immune system. So with that, we are helping a number of patients with long-haul COVID, and we look forward to helping others. Our phone number, if you need help with that, is 615-815-5941. One of our patient support staff will answer that. But for right now, again, this is an educational session, which means a good teacher is always going to ask if there's questions. We did have one question already sent in that I'm going to start off with, and then I will let others in the comment section leave more if you'd like to. My 5-year-old daughter had COVID in February. Soon after began having complaints that her heart hurt, it was beating fast. Currently going through cardiac workup that's been normal so far. Halfway through 1 month heart monitor. Something is COVID related. Will these symptoms resolve, or on their own will it be a long-term issue that we're dealing with? So we're talking about a 5-year-old. So kids don't get as much of the acute COVID severity. However, in some, in a week or 2 or 3 after their mild disease, some children can get a multi-inflammatory systemic response where they have this kind of similar to some other things we deal with in kids, something called Kawasaki's, where their just body's super inflamed, their markers of inflammation are off the charts. Those kids those ones right at that point do pretty well with anti-inflammatories, even using steroids and therapies. But what we're talking about here, yes, even kids can get some leftover symptoms. Sometimes it appears that there's actually the virus gets into the heart muscle and causes something called myocarditis, but it is also, the virus can leave effects on our autonomic nervous system. The autonomic nervous system being that part that controls the things we don't have to think about. So you don't think about breathing, you don't think about your heart rate, you don't think, oh, my blood pressure is 123/70 and I want to turn it up to 128/72 with a thermostat. No, these all happen automatically in your autonomic nervous system. It appears that the virus may have some effects where that control mechanisms go a little haywire of the involuntary systems. So they're left with either palpitations, they're left with trouble breathing, with blood pressure fluctuations that can cause fatigue or dizziness. So in this case, for 5-year-olds, as I mentioned, we're still learning. For the most part, kids do a little bit better in general with the acute or post-COVID, but we can't predict in any one patient, oh, is this going to go away in 2 months and you've got to sit and wait it out? Or are there things, and I would say, yes, there are things we can do to speed that up. So even if you are going to get better, especially your child in 4 months, wouldn't it be nice to get them better in a month or 2? So there are situations where we're working, we've worked more with adults at this point, because again, those are the ones who mostly get the post-COVID long hauler, but helping kids with these is something we do as well. But yes, hopefully your daughter will see improvement over time, but I would get her to see someone who can guide and see if you can speed that up and leave as little leftover residual symptoms as possible. So I'm looking. All right, we've got some people leaving some questions. I appreciate that. What would you suggest for someone suffering cognitively post-COVID? So again, the mechanism is probably a dysregulation of the immune system with ongoing inflammation and potentially some endothelial damage, which may be causing microinfarcts. Stroke is an infarct. A stroke is a big one where you really have a major nerve symptom, but there's concern that there's areas in the brain that are not getting full 100% blood flow, and that's causing those neurologic symptoms. So what we would do is recommend the anti-inflammatories like the glutathione, the curcumin, the vitamin C, making sure someone's vitamin D level is good even after COVID. is protective against early COVID, but it's also helpful long term in modulating your immune system. From there, we would also look at controlling inflammation and then giving your brain healing things once inflammation is down, phosphatidylcholine, making sure there's a good omega-3 fatty acids, and also, again, looking around, is there anything else besides COVID that's contributing inflammation or preventing repair, getting rid of too much of the bad stuff and adding enough of the good stuff in there. So those are some of the things we would look at to get someone over those neurologic symptoms. We'd also, I will say, there are things you can do short of blood thinners. Yes, taking a baby aspirin may not be a bad idea after COVID, especially if you have some neurologic symptoms, to keep from small blood clots in your brain or other body tissues. Or we would look at using things that also thin the blood slightly, like curcumin, omega-3s, vitamin E can be helpful in those cases. Thank you for that, Ms. Benedict. Holland. How accurate do you believe that antibody testing is? So this is not exactly post-COVID, but it does play a role because to have post-COVID, you have to have COVID in the first place. How do you know you had COVID if you didn't go get tested? What I would say is the infamous PCR testing, which was overblown, and what I would say in another time we can talk about this. There was many more cases diagnosed than actually had it. The PCR test being too sensitive, whereas now the antibody test, which is when you're looking for the markers of your immune system having seen an infection before, seems to wane in 2 or 3 months. So that way you might check your antibody levels at 4 months and like, oh, look great. Well, did I have it or did I not? I sure felt miserable back then. Or I know I had it. I did a PCR and now my antibodies are gone. Not everybody has persistent antibodies. We see that with other viral illnesses. Some do and some don't. If you especially have very high levels, you're concerned maybe there's some ongoing replication of your symptoms, for example, EBV. But with COVID, the antibody testing seems to go down, and we don't know how protective those are from a future infection. Probably usually are, but some may or may not be. So it's not super dependable, but it's more if you have the antibodies, yeah, you have COVID at some point. Doesn't mean you have post-COVID right now. Just because you got COVID doesn't mean you couldn't have another illness 2 months later causing you the same symptoms that confuses with COVID, post-COVID. However, if you had the positive, you've had it. The problem is if your antibody levels are negative, you still could have had that, especially if it's been 6 months ago that you think you had the symptoms. So actually there's a commercially available T-cell test that's actually more looking at the memory function, meaning the antibodies may go away, but this can tell if your T-cells have seen COVID before to know, oh yeah, you had COVID. Now, just on another side note, some recent research, looking at, for example, antibodies, there's a question, why do kids not get it? Or why do some people get milder? Well, some people have antibodies that cross-react with other coronaviruses, which cause the common cold. That antibody, and one they've identified, binds a different part of the spike protein that doesn't change versus the one the spike protein that changes and causes us to need different vaccines or be able to get the same disease twice, is because that mutates. But this unchanging portion, antibodies, and even unchanging across different coronaviruses, from the nasty ones like COVID-19 to the mild ones like the common cold, can serve so that antibody works across there. Now, with memory T cells, you're actually looking at a more cellular process, not just single antibodies, and that is probably a better, truer test that has just come out in the last few weeks, commercially available. We knew about it for a while, but it was only in research, so that is something that I'm actually waiting for the first patients to come back, getting that test, so we can tell them whether they did have COVID in the past or not. So it's somewhat dependable, but it always takes an interpretation like any other medical test that we're doing for anyone else. Some people, so thank you for that question, either Chris or Ashley Holland. Ms. Butler, some people who had long COVID report they feel better after receiving both mRNA shots. What's likely happening with that? It's not clear. So yes, there are some reports that people feel like that suddenly all their post-COVID symptoms went away with that. We don't know if that's a stimulation of the immune system, immune response to turn off that dysregulation. Is it that actually there was ongoing virus and the immune system then clears it with a vaccine? We don't know. It's not enough reason for me to say, oh, if I had COVID, I would not, or a patient had COVID, I wouldn't recommend they go out and get it. There was just a study that's looking at saying that probably the vaccine doesn't really provide much benefit if you've already had it, because probably the antibodies you produce from the natural infection are probably better than what you would get from the vaccine. So it's not clear that there's any good to get that, except some people may want to try that to see if it helps their post-COVID. I've been trying to sort out what a mechanism might look like for that, but I haven't really come up with one just yet. Mr. Wilburn, you may have already covered this, but which company's vaccine do you recommend? So without getting down the rabbit hole of vaccines completely, right now I'm waiting to see who I'm recommending, if any at all, just because I do have concerns about the mRNA virus vaccines and the potential for causing issues. The short answer in that is recent research is showing that the spike protein is probably what is causing a lot of the hyperinflammatory response, the clotting. It's actually the trigger or catalyst. There are some even coming out research recently concerned that it looks like a prion disease, a protein disease where you don't need DNA, but it's actually autocatalyzes changes in your own body's proteins to replicate. So mad cow disease is one of the examples of where this happens. So whether or not we're going to see, as the mRNA stays around in the body longer, because originally, it only, spike proteins are only getting made in that muscle where you got the shot. Now they're finding the spike proteins show up in ovaries and other body tissues. So we're learning a little bit about this mRNA technology, so I would be concerned with that. And then the adenovirus vector by the Johnson & Johnson vaccine does not seem to be as effective. So its one-shot promise is probably not that good, whereas I wouldn't be surprised at some point saying they really need to get 2 shots for that one. So I am right now telling patients that wait for the better option, especially as the numbers have plummeted in the area for COVID, as we're not there to get that, because all this hype about herd immunity is not real clear. We don't have, it sounds like, let's trust science. Science is not that trustworthy. It's not that they're trying to lie for the most part, but they're claiming they know more than they really do about the herd immunity and the safety of the vaccines. You're welcome, Ms. Benedict. Does a mild case of COVID-19 produce the same amount of natural immune protection as a severe case? So there's some debate. It does seem to have a immune response that has some level of protection, but it does appear that many of those with a more severe disease have stronger antibodies to protect them from future disease. Now, problem is, if it's so severe, it can make someone temporarily immune suppressed, so you may be more prone for a few months afterwards, or if you're having some of these post-COVID symptoms, we don't know right now whether people are going to get more infections or are they more likely to get reinfected. So it does seem that a more severe infection offers more future immunity, but it's not completely clear yet how much of a difference. Is it a little difference? Is it some yes, some no, or is it a huge difference? We're kind of learning, doing the studies now to find that out. And keep hearing the classification of mild versus severe. What are the definitions of these classifications? So I'm not sure if you're asking about acute or post, so I'll answer both questions. Why not? Acute, the severe is hypoxemia, low oxygen, requiring hospitalization, and the most severe are the ones that are getting in ICU with intubation, putting on a ventilator. That was in the acute side. On the post-COVID side, I don't think that there's as much of a severe versus mild in that, so I think it is more of an acute question. But on the long hauler, I would say probably those that are having it longer and who are having symptoms so severe that they are not able to work, not able to go to school, missing other activities. So with that, I think that would be the easiest way to divide that up. Okay. I'm not seeing any other questions just yet. So we've got a few more minutes here though, so if anybody does have any burning questions, and I will think about are there anything else I can add to what I've already said about the long hauler COVID. Talked about the definition, we've talked about who gets it, the mechanisms. I'll throw one more thing out there that I'm investigating, so I haven't started doing this yet, but there is some question whether ivermectin, one of those forbidden medicines, the no-no medicines, they don't really work, when actually they do in other countries that are using them. One of the conferences I've been listening to lately is considering whether ivermectin is preventive, lessening the chance of you getting long hauler COVID, and there are some that are actually trying to use it in post-COVID patients to see if they can turn down the inflammation. It's interesting in learning about the mechanisms of ivermectin. It appears that it has some, it can turn down the NF-kappa B pathway, the pathway that's your inflammatory kind of signal. It's like the hub for a lot of your other inflammatory responses. It appears that ivermectin can turn that down along with some other places where it interferes with the virus spreading or growing. So that is something else I'm looking at. Also looking at what other therapies. There's a lot of different groups are going to be trying different things and determining what's the best combination. Lung disease. If someone's having a lot of breathing trouble during acute, you can look at doing like an inhaler. Besides taking steroids by mouth or IV, you can do inhaled steroids to turn down some of the inflammation in the lung. And with patients who are having prolonged lung coughing or breathing difficulty, I think that's a reasonable option. It has very low side effects. It's approved for asthma, COPD. We use it all the time. It's a safe medicine. I'm sure the FDA will decide at some point that it's dangerous to use something we've been using for years, but for now, like an inhaled steroid might be something that helps for 2 to 4 weeks to lessen some of the respiratory symptoms. See if anybody else has thrown out some questions. Any truth to certain blood types handle the COVID infection better? There is some debate about that. Some have shown yes, some no. Still, it's not so stark of a difference that I feel like it's necessary that people need to know their blood type. Now, maybe people want to know that because they want to decide whether they're going to get a vaccine injected or not. But in terms of just the average person, I wouldn't necessarily say go out. The differences have not been so different. Oh my goodness, twice as likely if I have A versus O, which I'm not saying that is the ones, but it's more of a very little difference. So I would not worry about that unless a new study comes out that shows that is more important than we realized. Thank you for that question. All right. So I'm going to kind of bring things to a close. I got one more question. All right, I'll keep going here. NIH case study, patients with COVID include one severe case who used nasal spray Xlear, were all able to clear virus in 7 days. Xlear, now in clinical trials, had experience with this nasal spray in COVID patients. So we use Xlear. It's a xylitol spray. Some of the forms of it, it comes in different forms. Also uses some essential oils. Essential oils do have some antiviral, antimicrobial benefits, so it is possible. I think there's a plausible mechanism of action. I've not tried that yet, but I would be interested to see what the results of that study are. We use that therapy for a number of other reasons, for allergies and for sinus infections in patients or prevention. I had somebody add that to their sinusitis prevention program this morning, in fact. So I'll be interested to see what that shows, but I have not been doing that just yet, specifically for COVID. Is there any evidence? There we go. A little pressure and everybody's pulling out some questions. I appreciate it. Is there any evidence for shedding of the vaccine, not the virus, for those who have been vaccinated? Does this present an issue for those with autoimmune issues? So, one of the million-dollar questions right now, can you shed spike protein from the vaccine? I will say, when I first heard this, I was a little skeptical. Possible, maybe, but I had to think about it a little bit. Now, because supposedly this mRNA is supposed to be gone in a week or two at the most. Like I said, it's supposed to be limited, but as we're seeing that is spreading throughout the body, so if the mRNA is causing you to produce spike proteins in multiple body tissues, definitely could be something that you would inhale in some of those droplets. It could be something that you shed on your skin, and I will say with a number of patients who have new symptoms that are really odd, like bleeding or blood clots, when they've been around others with who have gotten the vaccine or been in large groups where likely there was a large percentage of people, say in a plane, with vaccines. So I believe it's very possible, as we've got information, study data showing that the spike protein may be one of the instigators, the catalyst for the actual disease, even in acute COVID, is the fact that it is possible that they could be shedding that. I know they've been working on self-spreading vaccines. That concept has been around for a while. If you give one person a vaccine, that you're actually vaccinating people all around them. So it means you have to give out less vaccines. The problem is you get some side effects, unwanted side effects from those people who did not consent to getting vaccinated through someone else. So it's going to be interesting. If we can get the truth out, I think it's definitely a plausible fact. I think it's reasonable to think some people could be shedding the spike protein. I'm 9 months post mild COVID, still experiencing the sensation of having inhaled secondhand smoke for a long period of time. Something you've heard from other patients, and inhaler would be something worth looking into. So yes, there's a lot of these abnormal smells. That was one thing I forgot to mention. So the loss of smell, and then some people smell when it returns. They smell good, sweet things as smelling like rotten fruit, or they smell different smells that should be smelling good, smell bad. So there's some opposite smells. And we know that Vanderbilt is doing a study right now looking at using essential oils, retraining the nose with essential oils, and seem to be having some benefits from that, but they're working on that study. So there's also an NIH study looking at whether a medicine called theophylline, which used for asthma and COPD in a distant past. When I started practicing medicine 20 or 30 years ago, this was used more often, but we have better meds for those asthma, COPD, and emphysema now. However, that theophylline nasal spray supposedly does improve the chance that the smell will return. One of the things about that is it appears that the cells around the nerve cells, your smell nerve cells, the olfactory cells, the surrounding cells are the ones that get damaged. So if you can restore that, however, it does seem like sometimes it's a dysfunctional restoration of smell. And again, there are many who are looking. Whether or not an inhaled steroid, then in the lungs probably wouldn't make any difference. Whether you use something like a nasal steroid, I have not seen any research, but hopefully someone out there is looking at that as a possibility. Because of the effect on blood supply, would you recommend banking your own blood for optional surgery? Community blood bank requires must be vaccinated to donate. So I've had some other patients ask about that. We don't know quite yet. Is it possible that people who get vaccinated are going to have some ongoing leftover, well, they should hopefully have antibodies and memory B cells, the cells that make the antibodies, still in their body. And if they're donating blood, they're giving some of those. And if you're getting the blood donation, you may be picking up some of those. So there is a question. Now, if somebody donates their memory B cells, it's stored over here, and then they take it out, they typically will try to take out the white cells just because they cause more of a reaction when you give it to someone else. However, even if they make it into the other person, they're going to be gone in a few weeks to months at most. So it wouldn't be a permanent effect from what we could tell, but whether that spike protein was continuing. They claim that the spike protein is not made for more than a week or two. I'm waiting to really see, since we are still using experimental drug therapies, not actual vaccines that have been approved, because this is a genetic program, not a true vaccine in the classical sense. So we need to wait another year or two before we know that that's a big issue. But if someone has that ability to do some blood banking, especially if they're going to have a surgery, elective surgery that they can plan for, it's an emergency surgery. I wouldn't necessarily go give away your blood every 2 months to save some waste that you never use. But if in 3 months I'm going to have a hip surgery, and you want to go do some blood banking and donations, you can do that. It's probably not a bad idea. I think if I was facing that, I'd probably consider doing that. But we'll, again, know a little bit more, hopefully, if we have true studies telling us the truth, revealing that what's actually there. We'll know more here in the next year or two. All right. Those are some great questions everybody pulled out once I put a little pressure on that we might finish up early. Any last questions before we wrap up here? Okay. Well, I appreciate, again, all the questions, all the visitors, and if you're watching this after the live session, I always look back, so if you ask other questions, I'll try to answer them. And also, I'm deciding whether or not we talk a little bit more about post-COVID at the next session we have, which is, I'll give you the date on that, so you'll know when to be looking for it. It looks like July the 8th at noon, same place, different day, different time. Well, same time, different day, different place, whatever. You know what I'm trying to say. It's one of those days. So I look forward to seeing you on the 8th. Send questions, and if you want to talk more about long hauler COVID, put that in there, and we will talk more about it next time. Otherwise, I will come up with another topic that is of interest to everyone. So I look forward to seeing you then. Have a blessed day.